got enough money to break it and buy it. I don't. Maybe I ought to send that, then they know what we're really doing. Did everybody get one of these? Yeah. That's what I need to do. I need to pull it up in here. I think that's fine, but better than nothing. I thought I did. So I'll go to the commissions because that's on it. So I'm okay. A couple more minutes.
All righty. Everybody's turning their quiz in? Okay. Hopefully you saw my emails. I sent one last Friday, and I sent you the 27 rhythms. And I asked you to go over your PowerPoint. Make sure that you go over the 17 steps of the order of the blood flow, the 27 rhythms. We're going to go over the skill stack most likely on Wednesday. That'll help you to remember. We touched on the 5 steps. All of this is in your packet, so please pull out your packet in addition to what you were given this evening. Pull this out, okay? And then also the packet that I gave you on the first day of class. You're going to always want to have that in class, okay? We're going to go over the PowerPoint that was sent as an attachment in your email. Does that sound familiar? Okay, where it goes over, you see the blood flow of the heart and then the 17 steps, and then now we're going over that PowerPoint. Okay, so if you want to take a picture or write this down, please take, like I say, judicious notes, meaning that I want to be very specific. And I am recording this, so if you need a refresher to review this over the break, please make sure that you review this. You have to know this. Ms. Jones, who is one of our star instructors here, yay, she is going to be presenting this tonight, the 27 rhythms. So please give her your undivided attention. And without further ado.
All right. All right. So I hope you all brought your good brains tonight, because it's going to be a lot of information. But I hope that how I broke it down is going to help you digest it a little bit. Now, this is information that you cannot just look at it one time and think that you got it. It's stuff that you're going to have to make sure that you are looking at over and over and over again. It is like learning a new language, right? This is foreign. It looks like a bunch of lines, humps, and bumps right now, right? However, They will all make sense in just a little bit, okay? And so I strongly encourage you to go over this just like if you were learning Spanish, right? If you were learning new vocabulary words, you would look at this over and over again, okay? So you have 27 rhythms in your book. It's probably one for each chapter. One lovely PowerPoint to help it make sense to you. Okay? All right, so some key points just before we start to make sure that we're understanding and knowing. We definitely need to know what our P wave is. What is our P wave? Okay, it is our atrial depolarization, okay, where we're getting that response to the SA node. What is our SA node? Very good. Okay, it is our pacemaker. So, don't know what that is? That sounds important. Those of you who haven't had me before, when I say that sounds important, it's probably something that you should write down and know, because you'll probably see it, hear it again somewhere in the future, maybe near future, or very close to. Okay? So SA node is what? Very good. Okay? All right, so our first little hump there is the P wave. And then we have this kind of PR interval that goes kind of from here to here. And it is kind of where we're getting this filling, if you will, of our ventricles. Right? It's a little bit of a delay, and it's allowing those ventricles to fill. Because then we get to our QRS, which is what? Very good. Okay. Our depolarization of our ventricles. So it's triggering that main pumping contraction. Okay, so we see that big spike. Oh, sorry, just kidding. You don't. Just kidding. You see this big spike. Okay, that is your QRS complex in the middle. And you also will see kind of this ST segment. Where it's the beginning of repolarization, you should see it very flat right there. And then you'll see your T wave, which is what? Yes. And then sometimes you'll see a U wave, but a lot of times it's not there. And that will be our AV node specifically. But most of the time, you won't see it. Okay, so it'll kind of be flat and go into our next P wave. Okay, so when you're looking at your rhythms, okay, you should see this uniform across PQRST. Okay, and once we start to break apart those things, you'll notice changes and all that good stuff. Okay? So make sure we know what these parts are first. Okay? What is the SA node?
Pacemaker.
Now, this is the basis of how we identify every one of our rhythms. Okay? The basis. Every time we look at each one of our rhythms, we are going to go through this process for each and every one of them. Okay? First thing we're going to look at is rhythm. What is rhythm?
With the beat.
So rhythm is what that kind of beat is doing, right, along the way. So that drum beat of our heart. And is it regular? We're gonna look to see if it's regular. Okay, so it can be a regular rhythm all the way across, okay? Or it can be irregular, which is, right? So that's irregular, right? It is not consistent throughout. It can also be regularly irregular. So it can be irregular, but it'll be at a regular rate. That makes sense. All right. So it'll sound irregular, but it'll be continuously irregular. Okay. We'll see what that looks like. Now, rate. We're 70 to 80 is going to be normal, but 60 to 100 beats per minute is still going to be within normal limits. All right. Now, what is less than 60? What is that considered? Very good. Y'all have been learning. Dr. Williams hasn't been standing up here for nothing. What is over 100 beats per minute? Very good. All right, so there's a few ways that we can look at rhythms. So our 6-second method, wrote up here, in case y'all forgot, or 1500 method. Sometimes we use 300 method as well. But when we're looking at atrial rate, so we can look at atrial and ventricular rate. So most of the time we're looking at ventricular rate, which is that R to R, or looking at that QRS complex. Most of the time we do a 6-second method, right? We count how many, what?
How many QRS complexes?
Yes, and then do what? Multiply by 10, okay? So typically we'll do, is that right? Okay. Right, times 10, which y'all know what that meant. Anyway, so 6 seconds, and then, so we take however many QRS that are complete and multiply by 10, okay? So we normally do that. However, if we want to be very specific, and some of them, we may want to look at specific parts. So if we're looking at things in the atria, which would be what wave? Let's see who knows. Very good, okay? So if we're looking at things in the atria, we're going to look at that P to P. So we're just kind of calculating, even we can do 10 seconds with that from the P to P wave, each one of those. Or if we're looking at specifically ventricular, we're going to look at R to R, okay? And we can do 6 seconds with that too, okay? Next, we're going to look at the P wave, okay? Is it always before the QRS? So we know for it to be normal, our alphabet goes what? P, Q, R, S, T, right? So it should always be before our QRS. However, with some of our rhythms, you will see that it is absent, so it's missing. Some of it is buried somewhere else or behind the QRS. So we want to see if it's always before. Is it upright? Again, it can be inverted, so it can be upside down. Is it uniform? Uniformity means, are they all the same size throughout? So they can be bigger here, smaller here, going across. Okay, so we're looking at uniformity. Make sense? All right. And then again, that PR interval that I talked about, we're going to measure that. Okay. And for it to be normal, it needs to be 0.12 to 0.20 seconds. That's about 3 to 5 of their little small boxes. And then for our QRS complex to be within normal limits, right, it needs to be 0.04 to 0.10 seconds. So it'll be about 1 to 2.5 boxes for it to be normal. So we know our QRS complexes are typically small, right? That complex, that spike is normally small, so it's about 1 to 2.5 boxes. Now, it can be very narrow or it can be very wide. If it is very wide, something off. Right, so we're looking at that. Okay, so these are the things we're kind of going through our steps when we're looking at them. Some of them you can pick up right away very easily. Some of them you're going to have to look at a little bit deeper to see if, okay, do we have this PR interval? Is it 3 to 5 boxes? Our QRS complex, is that our 1 to 2.5 boxes? Okay? All right, everybody got that part? Yes? Yes? Yes. Anybody lost at this point? Nope. All right. So, our first one. This is your normal sinus rhythm. Okay? This is somebody who has a normal heart. Everything's going good. Everything's fine. There's no diseases going on. This is the only rhythm that every one of those steps are within normal limits. Okay? Every single one of those that we just talked about are going to be within normal limits. Okay? So we look here. Can somebody tell me what the rate of this is? 70. Okay. Remember, anytime we are dealing with anything medical, remember to put your measurements before, after, or whatever it needs to be. We don't want to just say 70. 70 what? Are we talking about? What? Yes, dear.
I'm sorry. What are we counting?
So to get your heart rate?
Yes, ma'am.
All right. So first we're doing 6-second method. And to do that, so this is 1 QRS complex. 1. Okay. They're all complete. So meaning I see a whole PQRS here. This isn't cut off. So if my 6 seconds strip started here, I wouldn't count this one.
Okay.
I would start here. All right, so that's very important. Want to make sure it's a complete complex, okay? So we do have all complete here. So we're just going to count these and times it by 10. So how many do we see here?
7.
Yep, so 7 times 10 will give us 70. Okay? So our rhythm, if we look at this, now there's a little tool that we could use. It's called a caliper. And it kind of looks like, what is that thing called? A protractor?
Yeah, that's like compass.
Yeah. Y'all remember that from high school where you kind of, yes, kind of like that. So you can tell the distance between each. If I were to use that caliper and put that between here, I would be able to tell that in between here, the P to P and the R to R, that rhythm is regular. That means they're equal distance. So I know that rhythm is regular. Okay, does that make sense? So from here, my P to P, if I were to go from here to here like this, this is equal. This is equal. This is equal all the way down. R to R, same thing, all the way down. Okay, so that checks my first box. We already did our rate, which was 70. So that's in our normal limits from 60 to 100. But we're doing, yes, I'm not gonna go ahead of myself because I was about to tell y'all something. So now we're looking at our P waves. Are all of our P waves uniform? Are all of them in front of our QRS? Are they upright? Yes. Okay. Are they different sizes or are they all the same? Are y'all sure? They're the same. If you were to measure these, they're the same. It probably looks a little distorted up here, but they're all the same. PR interval. So if I were to measure my PR interval, again, they will all be the same, so that's correct. And then our QRS, we're looking at how many boxes should my QRS complex be to be normal? Very good. So if I look in here, there's only one box. Okay. They're all uniform, right? They're all upright. Nothing's changed with that. Okay. So because of that, because all of these are checked off, they're within normal limits, this makes this a normal sinus rhythm. Okay. When we start to make any changes to this, then we will have some different rhythms. So look in your packet that I handed you that is numbered and see if you can find the one that is a normal sinus rhythm. Which one? 18. Say it out loud. 18. Very good. It is 18. Very good. 18 is your normal sinus rhythm. Please use this packet as your Bible. You will probably see these rhythms again somewhere in the near or distant future. Got it? All right. So we know what a normal sinus rhythm is. Now, if I were to slow this down and keep everything the same, I'm going less than 60. What did y'all tell me it was?
Bradycardia.
So how many beats per minute is this one up here? Okay. How do we get to that?
4 times 10.
Very good. Get that? Okay. So 40 beats per minute. So it is less than 60. Is everything else the same? Do I have a P wave? Are they uniform? Do I have a QRS? Are they upright? Everything else is the same. Great. If I were to put them, they will be equal distance. There's no changing in that. Okay, so the only thing I did here was take my foot off the accelerator and slow down. Okay. Where is that in your packet?
This is number 2.
What number do you guys up here think it is?
3. I think 3.
Is it 24? I thought 24.
So remember, we kept everything the same except slowed it down. So look carefully.
Is it number 26?
It's number 7. So look at number 7. Is number 7 less than 60?
Yes. Yes.
Okay, is everything there uniform? Are you all right? I know how I feel about germs. Good? All right. Now, what if I were to speed this train up, keeping everything the same? Sinus tachycardia. I'm going to show you it. Take a wild gander of what you think it might look like. Now remember, we're keeping everything the same. We're speeding it up.
It's a number 17.
Said 17. So it's not 17. Tell me why it is not 6. You said it was 6. Why is it not 6? Right. So remember, we keep everything the same. We're just speeding it up. It is 5. Okay, so we still have everything there. Everything is intact. You just sped it up. So it's over what? 100 beats per minute. Okay? Everybody see that on number 5. Okay? Please make sure y'all are writing these down as we go along. I promise you, you'll see these exact ones again in the future. It sounds important. I'm just telling you this because I feel it. I love you because I was already here once today. Please write it down. All right. So we got a normal one, we got a fast, and we got a slow one. Okay. All right. Now, what if I changed the rhythm but kept everything else the same? Say it out loud.
Dysrhythmia.
Dysrhythmia. Okay? Does everybody hear that? Dysrhythmia. So I'm keeping everything the same. So I still have a PQRS T. Okay? But I am messing up that rhythm. So it's doing some fluttering of some things or some missed beats and so forth along the way. Okay? So heart remains within normal limits, but it's having some variation. So when people breathe sometimes, there's some changes in the heart. So it can cause some dysrhythmias there. So you'll see that. What are some other things? If there's some tension or some pressure on the chest, it can cause some irregularity with the rhythm as well. So, rate is going to be 60 to 100 beats per minute. P wave is going to be good. That PR interval is going to be that 0.12 to 0.20, and then our QRS again is going to be 0.4, 0.6 to 0.10 seconds. So we're messing with the rhythm. Meaning, again, if I had my calipers up here, now we're to put my calipers from my P to P and try to go here, it's off. They're not equal distance. Neither is my R to R. See how it's giving me extra space? They're not the same. So it's messing with my rhythm. Okay. Everything else is the same. So which one do you guys think it might be? Is it 11? want the number. What number? At 22. So,
Is it 11?
so quickly, real quick, look at 22. Tell me why it's not 22. I want y'all to start to think a little bit deeper. Something's different about the P wave, right? Very good. All right. Who else said a number? So 17, not bad in your thinking, but this one is going to take a little bit of a deeper look in here, which I'll talk to you guys about in just a little bit. Not 17.
We agree.
It's at 11.
23. I know she can
It is number 8. Now, number 8 looks a little bit weird. Okay. However, we have our elements there, and because that rhythm is off, it's causing it to look a little strange. Okay. If we were to look at our P waves, they're all upright. They're all in front of our QRS. If we look at our PR intervals, okay, they're still going to be within normal limits, and our QRS is still going to be within normal limits, but we're looking at what? Here, the rhythm, okay? If we see that rhythm is off, okay? So because the rhythm is off, it's kind of making it push a little slightly, okay? All right. No.
These are the next thing.
Oh, sinus dysrhythmia or arrhythmia. We say interchangeably. So it can be dysrhythmia or arrhythmia. And with this one, we're looking at that rhythm. Okay, rhythm is off. Everything else is the same. Okay. All right. Now, next one, sinus arrest or sinus pause. When that SA node, what is the SA node?
Pacemaker of the heart.
It stops firing where we get this pause of electrical activity, okay? Other than the asystole, meaning what? Meaning what? We're flatlining, there's no rhythm, right? So we see this asystole right here in the middle, there's that pause. So other than that, everything else is going to be within normal limits, okay? So with this, we have to be very specific about this. So first of all, when someone gets arrested, right, we don't have time to think most of the time. Most of the time when people get arrested, they don't know they're getting arrested, right? It's kind of like we don't have time to really, prepare, right? So it kind of catches us off guard. So we have this kind of pause here, and you'll understand what I mean by that in just a second when we look at our next one. So we have this pause here that has no specific time limit on it, okay? In between where it's normal in the beginning and behind, okay? Everybody see that? So before this arrest, I'm beating along. I'm good. But then police came
and they just took my breath away. And now, all right, I realize I'm gonna be arrested and we gonna be all right. Okay? So, other than the asystole, everything else is within normal limits.
I think burns.
So again, this
There's a
one,
big gap right there.
you're gonna have to look a little bit.
I think it's 2. I think it's 2.
It's not.
There's like gap right there, right?
So I'm gonna tell you what this one is. Okay. Now, there could be more than one arrest in that particular 6 seconds. Okay, so it might not just limit that one pause there. Why is it not 20? So what's missing right here? Right, so it cannot be that. We're missing a hole. There's a hole asystole. So you cannot have a P wave and miss a QRS. And that's going to be something different.
Is it 2?
It is 11. It is 11. Very good. It is 11.
I know it's.
Okay. So sinus arrest. This next one can be a little bit tricky. Okay. Remember I said arrest. There's no consistency in that pause. It's like a thief in the night. You just snatched it, right? Y'all know snatch. Yep, okay. Sinus exit block looks like sinus arrest, right? When you look at this, it looks just like the one we just saw, okay? Difference with this is going to be a little bit more structured. So think about sinus exit block as I have a plan, right? If you have a exit plan, let's say for a fire drill, right? There is a plan probably somewhere on the door over there, near the door, that tells you if in case of a fire, we have an exit plan, right? So it's more structured. So this one is more structured, meaning if we see this R to R right here, it is a direct multiple of this pause right here. If I take this, multiply in here, it is equal. You cannot do that with your sinus arrest. That makes sense. Okay, so this is a direct multiple. So I can put this in here equally, okay, versus this over here. If I were to take this and try to put this in here, see how I'm left over? There's more space there. Because I came in like a thief in the night. I don't have time to prepare. However, with my exit block, I'm preparing. So there's more structure. That makes sense. Okay, now what number do you think that one might be? So this one, you're gonna have to look at it a little bit. And y'all are smart. It is 3. Sinus exit block. So number 3 is sinus exit block. So sinus exit block, you may see this as a result of acute heart attack. What is another word for heart attack? Look at y'all. It was important, wasn't it? Very good. All right, so we have normal sinus rhythm. Okay, what was bradycardia? Okay, our rate was
Less than 100.
less than
60.
Okay, tachycardia is what? Our rate is over 100 beats per minute. But it's changing with sinus dysrhythmia.
The rhythm is off.
Right, the rhythm is irregular. Okay? Inconsistent with our rhythm for that one. Okay? Sinus arrest. There is a pause there. Asystole. So everything before and after is normal, is within normal limits. Before and after, but it has that pause, but that pause can't be equal, right? However, when we have a sinus exit block, within normal limits before and after that pause or that block, but what is significant about this particular pause? This the direct multiple. So that R to R, I can put it in there and it will be equal. Okay? Are y'all good so far? Yes? Makes sense. Yes? Now, when someone has a premature baby, what does premature mean? It comes before its time, right? It comes before it's supposed to. Now, if I said premature atrial complex, what do you think would be happening? If I said premature atrial complex,
The
what do you think is happening?
The Pee-wee would be messed up.
So it's coming too early, right? So PACs, premature atrial complexes, occurs as a result of early electrical impulses originating in that atria. Okay, so of course it's going to interrupt the rhythm because it's happening too fast. Okay. So, just giving you some info about it. Your P wave is going to be still intact, still going to be positively deflected, so it's going to be upright. Although PACs are usually a benign condition, with each PAC, the atria do not have as much time to completely fill prior to that contraction. Okay, this causes less volume in the ventricles prior to ventricular contraction, and it may cause a decrease in cardiac output. So you may see some signs and symptoms of kind of low cardiac output with your patient that has PAC. Right? So, R to R intervals are going to be constant with the exception of that early complex. Okay, your rate is still going to be 60 to 100 beats per minute. Typically, your P waves are going to be normal, but they're going to be early. Because they're early, sometimes that premature P wave can be smushed into that one before it, right? Because it's happening too fast and not given enough time. So see how up here this PAC. So it's kind of smushing into that last beat, right? Because it's not giving it enough time. Okay. So what do we see here? Which one did we say? Which one did you just? No, which one did you tell me? No, who told you? You said it. Four? Yes. So look at number 4. See how the premature one is smushing into that one in front of it. It almost makes it look like an M. Okay. So everything else is normal there. But we just have that premature one is coming too soon. Okay, it's smushing. All right, are y'all breathing? You're not breathing?
Barely.
All right, I'm gonna give you one more, and then I don't know how long I've been talking. Y'all need a break? All right, so I'm gonna do one more, and then I'm gonna let y'all take a break, and then we'll continue. All right, so now, y'all ever heard of Cardi B song WAP?
Yeah.
So she stole it from EKG, because we had it first. You know, I'm gonna let her slide because I like her and all. You know, I won't tell her she on copyright infringement. But WAP is an EKG term for wandering atrial pacemaker. Now, I'm not gonna show you a picture of it, but I'm gonna tell you what it is to see if you can locate it. A wandering atrial pacemaker is going to have 3 different P waves. So they could be inverted, they could be large, they could be small, but the appearance of that P wave, there should be at least three different P waves. You're still gonna have that regular rate, 60 to 100 beats per minute.
10. Is it 13?
So I need y'all to look closely at your P waves. Some are gonna be upside down, some are gonna be normal.
Is it 23?
Look at number 22. Okay. You gotta look closely. I know the printing might not be that great, but look closely at 22, okay? You see how some of them are upside down? Some of them have a wider, some a little bit smaller. Because of that, what we call that wandering pacemaker, your rhythm is going to be slightly irregular. Not terribly irregular, but just slightly. Of course, that PR interval is gonna vary a little bit because we have a wandering pacemaker. Okay? So this is called the WAP, wandering atrial pacemaker. Okay, you have to have at least 3 different P wave morphologies. There's going to be 3 waves that look different for that P wave. Okay. So does everybody see that? If you do not, please let me know. I will come. Okay. All right. Are we good here? So far, are y'all okay? Okay, is it not so bad? Not so bad, right? Yes? All right, so somebody tell me, what is the difference between sinus arrest and sinus exit block? Very good. What is dysrhythmia?
The rhythm is off.
Very good. What about bradycardia?
It's slow.
What about tachycardia?
It's a minute.
Okay. What about premature atrial complex?
The P wave is coming early.
Yes. Okay. So we're coming prematurely. It's happening too soon. Okay. What about wow?
The P wave is coming.
Okay, so that P wave is wandering, and atrial pacemaker. Okay. What about sinus rhythm? Yeah.
Oh, heartbeat.
What is specific about normal sinus rhythm?
The rhythm is the same.
Yep. Everything is within normal limits. Okay? Y'all got it. We got it. We're just adding on as we go. Okay? All right, y'all take a break. And we'll continue after these messages.
I'm trying, this has to stop, but I can't keep missing class or whatever. It's for 5 hours. I don't get out. She's at the house, she's.
That's you. Oh, okay, just go back. Okay, thank you. Yeah. All right. So, when we are talking about we look at swimmers, right, we have, those who are good swimmers, right, who know what they're doing. And you will see, a term called flutter, right? So flutters are very uniform, when we are, swimming. And so when you're looking at your waves, okay, or flutters, they're going to be very uniform. So think about swimmers, flutters, uniform, okay? So atrial flutter, when we see atrial flutter, what happens is that upper chamber of our heart is beating too quickly. It's happening too fast. So it's giving us this quivering flutter impulse, if you will. And so what you're seeing there are really what we call F waves and not P waves. Okay, and see how they're very uniform all the way across? Okay, they all look the same, right? Because I'm swimming, I know what I'm doing as I'm fluttering along, okay? And that atrial rate is going to be very fast. So if we were to count all of these, this would be between 250 and 350. We talk about atrial rates, we're looking at these, okay? Our QRS is, as we can see, that is going to be within normal limits all the way through. Nothing has changed with that, but we're looking at those F waves now because we're fluttering, okay? So if we're fluttering, we're swimming, we have that nice consistent wave, okay? This is our Michael Phelps, I guess, if you will. Which one would that be? 13. Let's see. 13 is correct.
Are those R's?
I have a question.
Oh, I was trying to see if there's the R's over the, right here, on the board.
Yes.
There are F's. Oh.
So these waves that you're seeing, these are considered F waves because they're fluttering. They're not considered P waves. Okay. So these are considered F waves along here. So this is our normal QRS complex here, right? They're all along, but we get these flutters. So we have a nice wave going on. We're Michael Phelps in it, or whoever your favorite swimmer is, that's fluttering along, okay? So we're getting that, that impulse in that upper chamber is going way too fast, okay? And when we see this, we really need to pay attention to it because atrial flutter can change over to atrial fibrillation, okay? Fibrillation is, I have now fluttered for so long, I am tired, and now my swimming has become chaotic. So where I had my F's are now going to be chaos in between. So before I show it to you, what do you think it might be? Is it 6?
21.
14. Because if you're 8, they're just flatlined, right? Right? You're 8, maybe, I don't know.
So we're still having a QRS. So remember, when we're talking about atrial stuff, we're talking about things in the P way. Okay? So our QRS is going to still be there. but we're talking about this chaotic fibrillating of our feet.
27.
It's what? It is 10. Okay? So, again, those are still considered F waves because there's no distinct P wave because you're getting that fibrillation, that quivering, irregular heartbeat. This can lead to clot, strokes, heart failures, different things because they're out of sync. Their upper chamber is out of sync with the lower. Okay? What is another term for a stroke? No. Danger, you know it. I see it coming off your brain. Starts with this C.
Is it cardiovascular arrest?
CVA, so cerebrovascular accident. Sounds what? Important. Okay. Cerebrovascular accident or CVA, which is strokes, your MIs, your myocardial infarctions, embolisms, renal infarctions, which is lack of oxygen to kidney tissues. All of these things can kind of be some issues when we're talking about atrial fibrillation. So again, atrial flutter, we're consistent with our paddling along. But when we have that fibrillation, I'm starting to drown. Now I'm kicking all over the place and water splashing everywhere, right? Okay. All right. Moving along. What did we say premature was again? All right, you have another premature. This one is premature junctional complex. Okay. This is going to be an early impulse originating in that atrioventricular junction. It is occurring before the next sinus pulse, causing irregularity in underlying rhythm. EJCs cause the rhythm to be irregular, and the P wave may appear before, during, or after the QRS complex. Okay? Regardless of the location, if the P wave is seen, it will be inverted. Very important. Okay? When we talk about junctional complexes. Regardless of the location, if we do see the P wave, it will be what?
Inverted.
Inverted, meaning it will be upside down. So, there's going to be a premature in that atrioventricular junction. So before I come up here, can anybody tell me where that premature junction might be on this one up here?
Where do we see it coming quickly? And an inversion. Very good. Does everybody see this?
Yeah.
Right here. So we're beating along. Now we get here at this junction, which is at our AV junction in here. We see we're going, it's happening too soon. But when we do see our P wave, we see that it's upside down right here. Everybody see that? Okay. Now, please locate. So it's going to be premature. Number.
Or is it two? You said it in 20?
Oh, what number did y'all say, sorry?
23. 23?
So it's not 23, but you're looking for the right thing. That is also a premature something.
But if it's two,
It is not 2.
12.
It is number 17. And there's a lot of PJCs on 17. So remember, if we see it, it'll either be before, during, or after, but when we see it, it'll be what? Inverted. So please remember, every rhythm is not going to look identical. You have to remember the parameters that we're looking under. So look at number 17. What is happening with this one? On our P wave, where is it located? So you have a couple there. So you have a couple of PJCs there, but where is your P wave in this one? So look at, yeah, so it is behind the QRS in this one. So do y'all see that? So you have one here. You also have one here. So remember, premature is coming soon. So we see beating, this is coming too fast. Beating, this is coming too fast here. But when you look at it, it's hard to see with this pocket. This is your P wave. See, it's inverted.
Oh, I see it.
Under there. Anybody else need me to show you?
Right here.
All right, so we're beating. This is coming too soon, right? So this one is premature. Now, when we look at it, it's hard to see on this one, but see behind here, the P wave is inverted. You also have one here. Thank you, guys. All right, we're beating. This is premature, it's coming too soon. And when we see it, the P wave is hard to see, but it's inverted. Yeah, and you also have another one. Right here. Anybody else need assistance. All right, slide this way so I can show both of y'all at the same time. All right, so see, we're beating. This is premature, right? Because this is coming too soon. This one right here. So this is the one we're gonna look at. But we're looking at this. See behind here? The P wave is back here. It's inverted. See, it's upside down. Yep. This one you can see a little bit better, but you kind of wrote over it. But this one is premature too. And
Okay, that's the one I saw earlier and I thought I was tripping.
yeah, so this is one too. So as they go along, they're still gonna be premature, but this one is also upside down. So it's behind there. Anybody else?
I feel a little bit better because I thought I was just not there.
Rhythm is fine here, so this is premature, right? So if we look here at our P wave, it is inverted, upside down. It's behind the QRS. Beating. This is premature. See how this one's a little bit more defined. Your P wave is upside down. All right. So what's the difference between premature atrial complex and premature junctional complex?
You said,
So tell me what the difference between premature atrial complex and premature junctional complex is. So we're still talking about that P wave is coming too soon, but what is different? Which one? Junctional. So premature atrial complex, we're going too soon with the P wave. So it may be smashed into the one that's in front of it, but it's always going to be upright. Okay? With your junctional, if it is there, because sometimes it might not be, if it is there, it can either be before, inside of your QRS. So sometimes it'll look like this if it's buried inside. Okay, so this means that it's inside of your QRS. Okay, it's buried in there. That's what that would look like. Okay, or it can be behind. Wherever it is, it's going to be what? Inverted. Okay, so far so good. Yes. All right. Moving along. So that was number 17, yes?
17.
Yeah. All right. Now, what did we say about junctional? What did I just say about junctional?
It was the P is inverted.
Yes. Okay. So this next rhythm right here, junctional rhythm, or sometimes junctional escape rhythm, when that SA node fails to initiate that activity, electrical activity. P wave may occur before, during, after QRS, but again, if it's seen, it'll be inverted. With this one, very specifically, heart rate is going to be between 40 and 60 beats per minute. Okay, so two things we're looking at specifically here. Junctional, y'all might be too young to remember conjunction, junction, what's your function? But I always think about that because it's slow. Right, so it's kind of slow. So it's 40 to 60 beats per minute. And it's going to be, that P is going to be inverted. Okay? Pretty consistent with everything else along the way. But what do we see here? 40 to 60.
Like on the paper?
60.
Is it 24?
The 9.
So it's
Maybe
not
12.
12. That one is a little interesting. We'll talk about that. So remember, the P wave may or may not be there. And it's gonna give you a hint because this one not there.
Is it 24?
Still have our QRST.
Is it 2? 9.
It is not. So look at 9. It is between 40 and 60. Okay. We see that our QRST is there. What's missing? Our P wave. Okay. So it can be missing. However, if it was there, it would be inverted. Okay. Now, I know y'all like to speed. So we're gonna put our foot on the accelerator and speed it up just a bit. Okay? We're gonna go to 60 to 100. We're still gonna stick with junctional rhythm, but we're going to accelerate it. That means what? If it's junctional, I'm just talking about junctional. If it's junctional, so it may or may not be there, but if it is, it's what? Inverted. Okay? Before, during, or after the QRS. Okay? Accelerated, we are going to bump it up to, it's going to be 60 to 100 beats per minute. So what do you think this one might be? Let's see. Yes. You are right. Look at learning something all by yourself.
Can't see the name of it.
Lip brain.
What's this one called?
Oh,
Can't see it.
accelerated-
Can't see it.
Yeah, I can't see accelerated junctional rhythm.
Oh.
I think it's the way that, I can see it on mine. I can't see it.
Oh, the thing needs to be moved down up there. So it's going to be accelerated junctional rhythm. Okay, accelerated junctional rhythm. We put our foot on the gas, we sped up. Okay? So we're going 60 to 100 beats per minute. But junctional, we're talking about that P wave. It can be absent, but if it's there, it is what?
Inverted.
Very good. Now, junctional can also be tachycardia. So if I have junctional tachycardia, what is that going to be? Girl, you better tell the people. So what do you think that might look like?
What do you want to put?
Which number?
27.
Mark the note. 27 is right.
That's for junctional tachycardia.
Yep, junctional tachycardia. Okay. So remember with our junctionals, okay? Our junctionals, we're talking about that P wave, it can be absent. However, if it's there,
It's inverted.
inverted can be before the middle of the QRS or after, okay? So you have premature junctional, have your junctional, which would be what? You're just talking about your junctional, the P, okay? If you're talking about just a junctional rhythm or junctional escape rhythm, what is my heart rate? Junctional. 40 to 60. Very good, Jamisha. 40 to 60. So we start slow. Junctional, 40 to 60. When I hit the accelerator, it's going to be what? 60 to 100. When I get to junctional tachy, it is
Over.
it's going to exceed that 100 beats per minute. Okay?
Is premature junctional complex impact still 200?
Yes. So with that, we're just adding a premature beat to that. Everything else is gonna be the same with our junction. Okay? All right. Now, I'm gonna read this to you, see if you can tell me what it might be. So, supraventricular tachycardia, SVT. This is where you're going to have a rapid rhythm. It's going to be 100 beats per minute or faster above the ventricles. Okay? So when we look at that ventricle rate, it's going to be 150 to 250 beats per minute. It's hard for us to determine what that atrial rate is because the P waves are going to be unidentifiable.
15?
15?
What do you know? Yes. Patients that have SVT, supraventricular tachycardia, you'll see kind of normal to narrow QRS complexes, and that rate is going to be 150 beats per minute or greater. Look for signs of cardiac output. Signs and symptoms and rhythm changes need to be communicated quickly to a physician for treatment because tachycardia significantly increases our myocardial oxygen demand, so we need to get them treatment as soon as possible. Okay? So very good. Look at y'all. All right. So the next few, probably the next four, are, I would say, the most difficult. Okay? But I think you guys can get it. Okay? There are your blocks. Okay, we have a few blocks. And sometimes looking at them can be a little tricky, okay? But if you kind of take a minute, breathe, and look at it, it'll make sense. Okay? Our first one is gonna be your first degree AB block, where there's a delay in that SA node to the AB node, usually kind of around the AB node, where you get that slow delay. Now, what's specific about your first degree AB block? If you are looking at that PR interval, it is greater than 0.20 seconds. How many boxes is 0.20 seconds?
3 to 5.
Okay, so it is going to be greater than that. And it is going to be constant. Okay, what I mean by that is that pause or that delay in that PR interval is going to be constant across. Okay, so if we look here in our PR interval right here, if I measure this and I measure this one, these are the same. They're constant. There's no changes all the way across. Okay, this you have to look very carefully at. Okay, so I'm looking, your PR interval is going to be expanded. And they're going to be expanded the same length all the way across. 14. Again, I've got all of them. How many of you all say 14? What do the rest of you all say? You won't say 14.
I'm stuck between 14 and 16. Oh, yeah, I say 14. I say 14.
14?
Oh, wait.
Do we agree or disagree with 14? Based on what we know. So rate is the same. We see all this kind of looks the same. We're just looking at this extension constant PR interval. We agree? I think you are correct. So those of you who did not say 14, please look at it. Okay? Look at your PR interval. Greater than 0.20 seconds. It is constantly the same. Everybody see that? Yes? Yes. I'm a church girl. I like to get what's called call and response. So when the pastor asks for amen, that means y'all say amen. So if I say yes,
Yes.
I need to hear yes and response. Well, I don't think you get it. So do you get it? Yes?
Yes. Yes.
All right, now your second degree AB block type 1. Okay, I'm not going to show it to you. Walk you through it. Okay. Second degree AB block type 2, there is a disease or injury in that AB node. What happens is, you're going to get start with a small PR interval, you're going to gradually get bigger until you completely have a block, which means there is a missing. Yes, look at you. Girl, you can teach the class. So I start small. The next one is going to be a little bit bigger. Third one is going to be bigger than the rest. And then this is going to be gone. And then I'm going to start my cycle over again. So that next one after the block is going to be small again. And gets a little bigger, bigger, disappear. Which one do we think it might be?
It still says 100.
23. Which one are y'all debating?
When you're
23.
It is 2. So start small, gradually get bigger until we miss that QRS complex. So as this rate decreases and reaches levels of 40 beats per minute or lower, the patient will show some signs of that low cardiac output. This is usually due to inflammation around the AV node and is often a temporary condition that will resolve itself and return to a normal heart rhythm. All right, next one is going to be second degree AV block type 2, often referred to as your classical heart block. With this, you're going to see PR intervals as constant throughout, but you're going to be missing QRS complex wherever a P is. Okay? With this, the PR intervals always measure the same. Now you may see a couple with this. It's fine. So which ones are you looking at? So it is 20. Okay, does everybody see that? Our PR intervals are constant. First order of business. You see that? QRS complexes are missing, but wherever a P is, with the QRS complex, that PR interval is always measuring the same. Okay? I see that. Now, the next one is the same, but it's gonna just kind of take it up a little bit. So this is making it a little bit more specific. So I say you might see this. Another one that looks a little bit similar. So this is still considered second degree AV block type 2, However, we're gonna put 2 to 1 because wherever there is 2 P waves to 1 QRS, if there was 3, it would be 3 to 1. So why is it not 26? Tell me why it's not 26. Look at it closely. What did we say needed to be constant? So if we're looking at 26, are they constant?
No. No.
No, they're irregular, right?
Yeah.
So, which makes that one something different. Okay, so we'll look at that in just a second. So, just gonna give you this up here, just giving you a difference between your second degree heart blocks, your type 1 and your type 2. Second degree AV block type 1 is temporary. Okay, it's temporary. Second degree AV block type 2 is going to be chronic and more critical. Second degree type 1 is going to be where we see that steady increase versus type 2 is going to be constant throughout. Okay? Now, when we're looking at your third degree AV block, this is where you get your irregular PR intervals and you're missing QRSs. Okay.
So second degree is just constant, you know, every 7 years.
Yeah. So it is 26. So with your third degree, that PR interval is irregular. Okay, and then we have those missing QRSs. Have those missing blocks. Okay. This is up here to show you kind of the differences between your heart blocks. So when we look at your first degree and your second degree type 2, we're talking about constant. Okay, we're talking about constant. Okay, so first degree heart block, remember, constant all the way through. Okay, we're constant all the way through. We didn't miss anything but that PR interval all the way through. Constant. Okay, down here, second degree. Where's my? Oh, there it is. So second degree type 2, again, that PR is going to be constant, but this one we are missing our QRS complex. Okay. Second degree type 1, this is where we get a gradual PR interval, then we miss that QRS complex. Okay. Third degree PR is going to be irregular and we're going to be missing QRS. So this one, you just all over the place. Okay. Got it? Your third degree, you have irregular PR intervals. You're also missing QRS complex. Okay. All right. What did we say premature was? Happening too soon. If we say premature ventricular, now what part of this PQRS are we looking at? Ventricular, we're looking at the QRS now. So atrial stuff, we were looking at the P waves, right? So now we leave that alone. Now we're talking about ventricular, right? So we're talking about premature, happening what? Too soon. Ventricular, we're looking at QRS. So you're going to see that QRS complex is going to be coming too soon. Okay. So for PVCs, you get that early QRS that measures 0.12 seconds or greater. They're going to have this wide or bizarre appearance because they're happening too soon. Okay, there's no P wave there at that premature because it's pushing in there out of the way. So what do you think that one is? 61. Good guess. So when you look at 25, is anything in there premature? No, everything in there is the same. We're looking at premature.
23.
Something is coming to say 23. 23 is correct. So we are within normal limits. Everything is going along fine. However, we are mushing that ventricular. It's wider. It's looking bizarre here. It cut off that P wave. I see that. Also over here. Okay. This could be because of things like stress, caffeine. Those don't know me. Bed. Also alcohol and hormonal changes. All these things can cause PVCs. Okay. Now, we have something called idioventricular rhythm. So this happens, so it's slow, okay? Occurs when that SA and junctional pacemakers are failing to initiate impulse and giving you that slow ventricular pacemaker, okay? Very good. So P wave is usually absent with these. Yep, so there's an absence of your P waves and idioventricular is going to be 20 to 40. Okay. always think about idiots will be absent. Right? Idiots will be absent from class, so they won't pass with the P wave. P will be absent for idioventricular. And these are going to be slow. They're 20 to 40 beats per minute. Now, if I step on the accelerator, okay, remember we stepped on the accelerator before. What happened? The increase stayed in the same scenario. So if I'm going 40 to 100 beats per minute for accelerated idioventricular, P wave absent. What? 25. It is 25. Very good. All are wonderful. Now, I am now going beyond the speed limit to tachycardia. So we have ventricular tachycardia. So when we talk about ventricular tachycardia, P wave is absent because the ventricles are moving too fast. And it has this kind of sawtooth appearance. So we're going 100 beats per minute or greater.
13.
This is 15. It sure is 15. So this is ventricular tachycardia. All right. Almost done. Look at y'all.
What was the one before
So
this
very
one?
proud.
The one
Now.
before this one? What was the one before this one?
So before this, we were just at accelerated. So we stepped on the gas. We're 40 to 100 beats per minute. We're missing the P wave. So remember,
That's number 25?
idiots
Okay.
don't come to class. So they don't pass with the P wave. P waves are missing in idioventricular. Okay? So you can start off slow with our idioventricular rate, less than 40. Once we hit the gas, we accelerate that idiot. Put them at 40 to 100 beats per minute. And then once we go faster than 100 beats per minute, we're at ventricular tachycardia, no P wave, and we're greater than that 100. Yeah? Good? Yeah.
Mhm.
All right. So your next one, you're going to see, this is where you get kind of this twisted ribbon appearance, where you get a ventricular tachycardia, where the impulses are moving from one ventricular to the other. So it's going to be a twisted appearance. It's called torsatus of points, or torsatus de pointes. So it looks like a ribbon. Okay, the ventricles are giving you impulses one for the other. So it's twisting on you.
Is it 21?
21. This should be pretty easy to find. I don't know, maybe, did y'all have that in here? Actually, it's not in your 27. I put it in the back. So it's like second to last page. Y'all see that?
Oh,
Yeah. So just make sure you highlight that, start. You might see it on your test or something somewhere. There. All right, so what did we say fibrillation was? Close. So we are talking about kind of those weird waves, but when we talk about fibrillation, what is it? Yeah, it's chaos, right? So if I say ventricular fibrillation, which part is fibrillating? Yes, so that's not going to be distinct, nor will I have a distinct P wave. So it's going to look like chaos. Is it what?
21.
It is. Okay, very good. Look at you all. Smart. Okay, if we are flatlining, we have asystole. There is no electrical activity. You about to meet your maker, whoever your maker is. You about to go to the light, maybe even the dark. Depending on how bad you treat Dr. Williams. So asystole, you're just gonna have a flat line. So y'all know what a straight line is, right? Right there. All right, so you should have two left, yes? Dos más. Yes.
One.
Two.
Yeah, two.
So, looking at, which numbers are you? You have
One.
1 and 12. Okay. So, sometimes patients have to get help with their heart making those electrical impulses because they can't do it themselves. Okay? And so we put something in there called a what? Pacemaker. Okay? And so if they have a pacemaker, it will create a artificial kind of line in there. Okay? So if I have a paced atrial rhythm, what part is my pacemaker helping me with? Yes. So therefore, I'm going to see a spike in that atrial section. It'll look like a block or like a straight line where that P wave should be. Okay. So your paced atrial rhythm is number 1. I believe. Hold on. Let me look at it first before I lie. I lied. It's 12. Just kidding. 12. So you'll see that line, right, where it's supposed to have a P wave, and then same thing for your ventricle. there'll be kind of a weird line there, right, where your QRS is supposed to be. So that should be
Number one.
your number one, right? Okay, so you'll see a kind of like a sharp. Okay.
Is it what I'm looking at for?
Okay, everybody see it? So the ventricle one is that sharp line. You kind of see for that paced ventricular. Okay, so one is paced atrial, the other one is paced ventricular. So wherever that pacemaker is giving help assistance to is where you're going to see that spike before. Right here. Okay. Very good. All right. Now, I would hit the off the that. All right. So everybody should have them all written.
No.
Brad, what's number 16?
16 was second degree AV block 2 to 1. So it's just a more specific AV block type 2. We're just specifying it a little bit. All right. Tell me what a WAP is, a wandering pacemaker. Y'all up at the front. What is a wandering pacemaker?
The P wave is wandering. The P wave is wandering.
More specific.
Because
Has to be what? How many?
3 different,
Yes.
morphologies.
Yes. 3 different. Okay. 3 different morphology within the P wave. Okay. Tell me about idioventricular rhythms in general.
The P wave is absent.
20 to 40.
So P waves are absent in our idioventricular rhythms in general. Okay. Our idioventricular rhythm, what is specific about that one? What is our rate?
20 to 40 beats per minute.
Okay. What about if I accelerate it?
40 to 100.
Okay, very good. What about junctional?
They can be absent or inverted.
Did everybody hear that?
Mhm.
Junctional. We talk about junctional rhythms. What happens? Junctional.
Or inverted.
Absent or inverted.
Okay, very good. Who knows the difference between sinus arrest and sinus exit block?
It's like a direct equal sinus arrest is platform.
Sinus exit block is covered
Good.
and sinus arrest has a pause.
What's the difference between atrial flutter and atrial fibrillation. What do we call those waves? Instead of P waves, they're called what? Very good. What do we know about first degree AV block?
It's constant all the way through.
What's constant?
The first degree, atrial ventricular block.
Tell you what? What is that?
The,
What interval is
is it your
that? PR interval.
Oh, yeah, P1.
Okay. So we're looking at PR intervals when we talk about our different blocks. Okay, so our first degree, constant all the way through, right? But we still have our QRS complexes. Okay. What about second degree type 1?
What are you talking about?
I'm looking at the picture.
So, what happens? Say it again. Don't look at the picture. Tell me what happens. Or what? So we have to have a block, right? We miss our QRS, and then we start over. Okay? So it's like we're building up to the block. Second degree type 1 is gradual increase, and then we're missing that QRS. What about third degree AV block?
It's missing the QRS complex.
So we are missing QRS complex, and what else? Go ahead, Jamisha. PR intervals are irregular.
That's on the second.
That's third degree.
Third. Yeah, I
Yeah,
know.
I tricked
I know, that's all.
you. So third degree,
And missing QRS.
missing QRS, and our PR intervals are irregular. Okay, they're irregular. Okay, so next. Goodness gracious.
Wait, you said that was the second or the third?
That was the third. That's why I thought it was second.
All right, so tell me what is second degree AV block type 2?
It's a constant QR.
And what?
And it's,
Yep, very good.
Second degree type 2.
So that PR interval is constant, but we're missing that QRS complex. Okay. What is ventricular fibrillation?
it's chaotic.
Chaotic.
It is chaotic, but what? Do I have a P wave?
No.
Do I have an identifiable QRS?
No.
Okay, so everything is just all over the place. Very good. Y'all did well. Any questions, comments concerning emotional outbursts?
You said none of QRS. For the, ventricular, ventricular.
So yes, we don't have any identifiable Ps or any identifiable QRS because it's all just chaotic. Okay. Now, please. Oh, what is torsades de pointes? What happens?
It looks like a
Right, it's like a ribbon, right? It's twisting back and forth. What about asystole?
It's a line.
Flat line, very good. Now, please don't let this be the last time you look at this. It's important that when you walk away, stay. Go back when you get home, even if it's for 30 minutes, to look over it and say, okay, what is this? Why is this? Okay? And continue to look over it every day. I think Dr. Williams is going to give you the link to skill stat so that you can go through these. I promise you, if you look at it every day, we'll be able to fire these off in a matter of seconds. Okay? It's just a matter of push to the side the one that you know. So you know what normal looks like, you know what bradycardia, you know what tachycardia looks like, probably know what AFib and aflutter looks like, those things. So you probably can kind of identify those pretty quickly, right? So push those ones to the side, and then the ones that you need to do a little bit more work on, kind of focus on studying those a little bit, okay? Any questions? Does it make sense? Okay? Just kind of break it down when you look at each of them, like why is this? Okay? Hopefully you think of some of the little tricks, little sayings that I gave you to help you to make it make sense. Okay? If you have any questions, I'm sure Dr. will. Y'all can shoot me a message or anything. I will be more than happy to help. Okay? I think you'll be fine. You guys did great. And yeah, I'm done. God bless. See you next year. Oh, happy holidays. Oh, I just need to. I'm sorry. In mind.